Okay, welcome all. We're at the ICS Live Lounge today. We just finished a wonderful workshop this morning on neuromodulation, on sacral neuromodulation, and I had the pleasure of being a participant in that, and I have the pleasure today of having a nice interview time with two of my colleagues who are also in the workshop. We had a well-attended workshop, a lot of engagement, so I'm going to take this opportunity to kind of, check in with you guys and see how you thought. So I'll introduce our colleagues here, Dr. Marcio Averbeck from Porto Alegre, Brazil, all the way from there, and then Dr. Sarah McAchran from University of Wisconsin in Madison. And they're both here. They're both participants in the workshop this morning. I thought it went really well. Did you guys think the same?
I thought it was fantastic, and we just really had amazing participation from people from all over the world.
Right.
This called my attention as well. We have people from all the continents attending the workshop. This was amazing, and we could have the opportunity to exchange ideas, experiences, and mostly important is the way to discuss some strategies to overcome the barriers concerning access as well.
Yeah.
Right, when you guys decided to join in on this workshop, did you have any individual goals, or what were you hoping to achieve in the course of this workshop as we educated all these folks?
Well, I think that the ailments that sacral neuromodulation treats, so urinary incontinence, fecal incontinence, idiopathic retention, disproportionately affect women. And so the opportunity to bring this therapy, which can have such an amazing impact on patients' lives, to a whole part of the world or parts of the world that don't have that option, really allows me to, what I'm really excited about is the ability to positively impact women's lives really worldwide. And so being able to introduce this to a lot of people who've never seen it before is incredibly exciting.
Yeah. Marcio, do you have the same feelings?
I had a feeling about the usage of sacral neuromodulation in neurogenic urinary tract dysfunction,
yes,
which was the topic that I was supposed to discuss, and I received a lot of questions concerning the pros and cons, and I guess in these regards, the ICS white paper on S&M is truly important because it set the expectations, and as we mentioned during the workshop as a take-home message, we should only consider this therapy for patients with neurogenic urinary tract dysfunction whenever the risk for upper urinary tract dysfunction is low.
Mm-hmm. Right. No, that's a great point, and I really loved your lecture because it's interesting. I mean, I've seen a lot of successes with those types of patients, the neurogenically impaired patients. But as you've alluded to, I think so much is on selection. Mm-hmm. So what other criteria can you maybe articulate for the group listening about selection of the appropriate patient with neurogenic bladder who you may consider a therapy like this?
I guess that in comparison to the patients that don't have concomitant neurological diseases, I believe that urodynamics has an important role in patient selection, because it's only with urodynamics that you can define whether the bladder pressures are at a low threshold, and you can move forward. Then the second thing is to discuss the type of the pattern of urinary tract dysfunction. I believe that for neurogenic OAB, the chances for detecting responsive patients are a little bit higher in comparison to other different patterns, such as retention. I cannot tell you that the patients with retention will not have like the chance for a good response, but I believe it's a more challenging indication. And the third point that I believe it's important is to finally align the patient's expectations concerning therapy, and then we have the test phase, and we should set expectations from the beginning in order to avoid any problems concerning patients' expectations, I believe.
Yeah, no, I think that's a great point, and so much of that is also kind of alluded to and summarized in some of those white paper statements and things that the society's put out. Yeah. One challenge that we all see, I mean, so we're talking about niches with neurogenic and perhaps other patient groups, but how have you both kind of looked at getting more practitioners offering neuromodulation, right? So we're looking at niche groups, but also there's a lot of physicians who either gotten trained. Obviously, we had a number who came in today with hopefully the goal of eventually adopting this in their practice, but we're still seeing a lack of kind of a larger group, doing a lot of them. How have you kind of faced that challenge in the U.S.? And I guess certainly, Marcio, I'll ask you about how it happens in Brazil and other parts of Latin America.
So I do think that it's very helpful to have a much more specialized practice when you're trying to incorporate neuromodulation into it. It's helpful to have multiple, to have a large patient base to be able to do this frequently and often, and then also you need to be able to maintain an office staff that can help you support these patients. So to help with reprogramming, to help troubleshoot problems when they call in, and to do that, you need to have a pretty high volume. So I do think that being a somewhat regional referral center is beneficial. I don't know that this is a great thing to try to roll out if you're planning to do it 1 or 2 times a year.
Agreed. Yeah, I think you need to get a bit of a cadence and flow in your practice to have that. And it's sort of self-fulfilling, right? I mean, if you don't have that many of those types of patients, you're never going to get the resources around it. And then maybe to that end, maybe it is better served by someone else who's a regional expert like yourself.
Yeah.
And maybe they do all of them. Marcio, what have you seen as the challenges in Latin America for development?
I completely agree with Sarah concerning these points, but I truly believe as well that mentoring is a key factor. So if you are trained in a time in which S&M was not available, was not part of the formal training during your residency, it's quite difficult to move forward.
Yeah.
If you have a mentor, somebody that you can learn from, it's a key factor. The other point would be patient awareness.
Yes.
If there's no patient awareness, people will not get to know about the possibility of indicating sacral neuromodulation. And concerning Latin America, I can tell you that recently there was a prospective study published showing that concerning fecal incontinence, the responsiveness rate was above 90%.
Yeah,
so in these regards, this is from Latin America, okay? We should always remember that 1/3 of the patients presenting with OAB may also present fecal incontinence, what we call combined urinary and fecal incontinence. On the other hand, we had a chance to perform study which is called Brazil LUTS study. In the same way that the AP-LUTS has been conducted, we move forward to define what was the prevalence of OAB symptoms in Brazilians aged over 40. And we were very surprised to detect that 1 in 4 Brazilians presented symptoms compatible to OAB. So it's highly prevalent. We as urologists and all the medical professionals and healthcare professionals that are paying attention and taking care of these patients should know more about sacral neuromodulation.
Agreed. And I guess to kind of build on that, with the prevalence being what we know, and we know we're only scratching the surface in terms of the patients that we're talking about, bladder conditions, bladder dysfunction, as well as fecal incontinence. We're starting to see some of these new entrants into the market, and specifically on the implantable tibial side. I guess no one knows the answer, but I'll ask you both to kind of give your best thoughts as to where do you see that happening? Do you see it growing the market? Do you see it cannibalizing from one to the other? Have you thought in your own minds how an algorithm would look?
Oh, that's the question, the $100,000 question right now, right? And I don't know that I have an algorithm for exactly how to incorporate the variety of tibial options that are out there. I think sacral neuromodulation is such a proven and incredibly well-studied therapy. It's hard to make a change to something new. It's hard to make a change to something new unless we see huge benefits from the new therapy. So I think that's a question that still needs to be answered.
Well, all I can only agree with you, but I believe that the therapies are somehow different. I believe that the implantable tibial nerve devices may provide additional benefits concerning PTNE, PTNS, due to the fact that some of the patients are complaining about the need for frequent sessions. Sure. Attending the session somehow is a burden that we as physicians should be aware of, you know. But on the other hand, you can always think about how is the mechanism of action for these therapies. And I believe the mechanism of action is somehow different. For tibial, somehow we have like a carry-on effect for some of the patients. I don't see that too much related to S&M, okay? On the other hand, I had very large number of patients that underwent tibial, didn't present a good outcome, and then underwent S&M test phase and did present a response. So that I guess that there is room for both therapies, and as far as we have more options to treat these patients, this is a good thing. And I cannot wait until we have such devices in Latin America, because nowadays it's not available.
Yeah, and we're just getting it in the States, so I think, yeah, the story remains to be seen as to how that really fills out. Have you seen any other challenges to, again, broader adoption for this technology? I mean, again, we've trained a number of physicians nationally, internationally, really. We've trained sort of more people today, hoping they'll go on to the next steps and start to do these. Any other challenges you guys see with kind of like, why isn't everyone doing it?
I mean, I find in my practice sometimes it's still sometimes difficult to convince a patient to go through with sacral neuromodulation to treat their overactive bladder.
And why is that?
They see it early as a really drastic step for a quality of life problem. And so I think one of the ways, and this is what I talked about at the workshop today, is to start talking about it early on when you meet the patient, start to normalize it as a therapy, let people know that it was introduced in 1996. We have a lot of data and a lot of people out there who have this device where it's really made a hugely positive impact on their lives. But I think sometimes patient attitudes about this is a difficult thing to overcome, you know, in addition to just the bit of an infrastructure that you need surrounding a program like this.
I mean, on the flip side, do you see that patients sometimes are warming up to it because so many of our overall patients have heart pacemakers, spinal cord stimulators, deep brain stimulators? Like it's almost like, you know, bionic patients. So to add this, they're like, oh, really no big deal.
Especially with the pain stimulators becoming more and more common. More people have knowledge surrounding this and are a little more aware of what it can and can't do.
And Marcio, each country, as I've visited with you and others in Latin America, have sort of different rules. At the same time, have you seen other barriers to, you know, broader adoption? Is it, you know, like you alluded to, physician training? Is it patient awareness alone? Is it a reticence to even trying an implantable therapy?
Patient awareness is important, as I've mentioned before. Sometimes we receive some of these patients, particularly the ones with OAB, that come with a bag of all the medicines that they have received beforehand, and it's not in compliance to the current definition of the AUA guidelines, the AUA SUFU guidelines, in which you had like some insights which I believe are truly important, like one medicine in full dosage for at least 2 months would be enough, along with behavioral changes for 3 months to define refractory OAB. So this is a sad thing. Now, when we receive the patient with a bag full of medicines, and the patient receives all the antimuscarinics that we have available in the country, plus the beta-3 agonist, this is not good, okay? But one major barrier that we have in Brazil is the costs related to the therapy.
Yes.
Fortunately, the health insurances, they cover S&M for specific indications, such as OAB, fecal incontinence, and pain. Okay?
Interesting.
But we don't have in the coverage urinary retention. So the Brazilian Society of Urology is currently working in partnership with major stakeholders to include urinary retention in the coverage list. So we know that in Europe, urinary retention and OAB symptoms are already part of the coverage list. over the last 31 years when it was first registered. The US has also provided such a license, if I'm not mistaken, in 1999 for retention, not only OAB.
Yeah.
Correct.
And so we are facing some barriers, but we're moving slowly forward, and we believe that in the near future we can benefit our patients also with urinary retention in Brazil.
Yeah, well, that's fantastic. I want to thank you both for being part of this, and certainly part of the workshop. As you can see, there's a lot of challenges out there. We've overcome a lot in the last 30 years with this therapy, and we've done quite well. We made quite an impact internationally, but there's more room, to have in the future, and I think there's more room to grow. And we look forward to being part of the ride. Thank you.
Thank you.